the August meeting. The last meeting we had was on July 23rd, and we had an eminent speaker from the United States, Dr. Benjamin Tarain, from University of Arkansas of Medical Science, and he was talking on Barrett's esophagus. And the session was moderated by Sir and Dr. Arun Kumar. The meeting was well appreciated and well attended. And today we are indeed very much honored to have yet another stalwart in the field of gastroenterology, Professor Surendra K. Kumar Yacha sir, a very senior and renowned, and I should say an icon in the field of pediatric gastroenterology. Presently, he is the director and head of the Department of Pediatric Gastroenterology, Hepatology and Liver Transplant Unit at Sakra World Hospital, Bangalore. Warm welcome and thank you for accepting our invitation. Warm welcome from all the organizers and all the members of Trivandrum Get Club, sir. And looking forward to a very interesting talk from you, sir. And today's topic will be a case-based discussion on pediatric cases in gastroenterology, hepatology, and also pancreatic cases. And the moderator for the session is Professor Narendra sir, senior gastroenterologist and hepatologist from Cosmo Hospital and GG Hospital, and also Dr. Prashant, who is the assistant professor at newly the SAT unit of the gastroenterology at Trivandrum Medical College. And the sponsors of today's meeting are Sun Pharma. I thank them for arranging this meeting. And I invite and expect active participation all the members and all the residents, and take the full opportunity to hear Dr. H.S. sir on this interesting case discussions. It's a privilege, sir, to have you once again. And I request the coordinator to mute all except the speaker and the moderators. Of course, you may unmute after the session is over, or you can also open your video after the session is over. And the questions, I think, can be directed through the chat box, and also you can raise your concerns and questions after this session. And we'd like to the moderators to see that the session goes on in time, and we'll hear maximum from the speaker, the maximum number of cases, and we should be closing around 9 o'clock today. So over to you, Narendra sir and Prashant sir, to take over this session.
Yeah, thank you, Dr. Karim. On behalf of the members of the Trivandrum Gut Club, great pleasure in welcoming you, so for sparing your time to spare a few thoughts with us. I don't want to waste any more time. I will straight away request Dr. Prashant, the Assistant Professor of Pediatric Gastroenterology, to give a formal introduction of the speaker. Dr. Prashant.
Thank you, Narendra sir. Dear teachers, seniors, colleagues and friends, very good evening to one and all. I am in fact extremely grateful to the Trivandrum Gut Club, especially our Secretary Harish sir and President Professor Ramesh Kajan sir. Sir has not joined, he will join in due course, for the humble opportunity to share platform with the two doyens, including our speaker as well as our moderator. Our guest speaker is none other than Professor S.K. Acha sir, and the other moderator being Narendran sir, who is the senior gastroenterologist and former professor and head of the Department of Medical Gastroenterology at Trivandrum Medical College. Today our guest speaker is Professor S.K. Acha sir. He is currently the head of the Department of Pediatric Gastroenterology, Hepatology and Transplantation at the Sakra World Hospital, Bangalore. He was, on a personal note, I share over a decade of association with him. Sir is an iconic figure in the pediatric gastroenterology fraternity in India. Sir has an illustrious career spanning over more than 3 decades in pediatric gastroenterology, and has several firsts to his credit, including setting up of the first super specialty pediatric gastroenterology department at the Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow, and the initiation of the DM program in pediatric gastroenterology. A true Karmayogi to the core, Sir has been a key inspirational figure for me in my career, even though formally I have never been his student. The list of his accolades is quite exhaustive, and in the best interest of time, I have curtailed myself to a few of the accolades by Sir. Over and above, Sir is a down to earth and approachable person, even while occupying highest echelons in the fraternity as well as in the academia. Let us hear from Sir on his vast and practical experiences in managing challenging cases in pediatric gastroenterology, hepatology, and pancreatology. And also, I would like to welcome all the delegates who have joined us from far and wide. Delegates, please make your queries in the chat box, and we shall take up the question answers at the end of the lecture by Yacha sir. Over to Narendran sir to invite Yacha sir to deliver the August lecture. Thank you.
The stage is yours, Dr. Surendra Acha. You can take over. Thank you.
Can you see the slide? Okay. Respected Dr.
Sir, I think you're mute, sir. You're mute.
You are muted, sir. Dr. Yacha, sir, you are muted. You can press the space bar and see what happens. Could you please?
I'll do that. No problem. I'll do that. Can you see now? Can you hear me?
Yes. Now we can.
Oh, thank you very much. Respected Dr. Narendranath, Dr. Prashant, Dr. Ramesh, Dr. Harish, and eminent gastroenterologists of Trivandrum and Kerala. First of all, let me say that I know Dr. Narendranath for a long time. He has visited IGPJMS long back when I was just a junior faculty member, and he shared some of the work with, I shared some of my work with him, and he was sitting in a room. I recollect that. And he is a very, very big man in research, epidemiology of gastroenterology, which we are learning at that time and now also from him. And so my biggest tribute to Dr. Narendranath, a senior gastroenterologist. So let me share with you. See, pediatric gastroenterology 3 decades back, we were just blank. In 1980s, we were totally blank. There was no patient service which was dedicated. There was no diagnostic and therapeutic applications. There was no teaching and training program, manpower generation, or what we call the research. Nothing was available at the time. And then it was PGI Chandigarh where Professor Saroj Mehta, the founder, she took up the lead in pediatric gastroenterology. Along with her, there was Dr. B.R. Thapa, who was actually assistant professor at the time. And I joined the department as a DM resident in gastroenterology after having done MD pediatrics. And I worked there for a period of 9.5 years at Chandigarh. And thereafter, I moved to Lucknow, and that time Professor Naik, who was the head of the Department of Gastroenterology, he wanted to develop pediatric gastroenterology as a unit and a specialty broad in the long run. And in this direction, what we did, we have sown a seed of pediatric gastroenterology unit at Lucknow at the time. It was November 1991. And thereafter, I started going to different districts of UP and giving this message that we have pediatric gastroenterology and so on. And thereafter, what happened, we had a vision for pediatric gastroenterology along with Dr. Naik. We had already done MD pediatrics and DM gastroenterology, but this model was with little success. Most of the pediatricians who were getting trained in gastroenterology would get attracted towards the adult gastroenterology, or else they could not get the slots which were proper for them during that period for pediatric gastroenterology. Then what happened is over the period of time, with Dr. Naik, we started what is called the postdoctoral certificate course, which is post-MD, and this was open to all level in pediatric gastroenterology, exclusively for pediatricians. And this model worked very well at the time. But at the same time, we had a group vision that we start DM in pediatric gastroenterology in India, and nothing was actually done at the stage. We applied to MCI, our whole group, at the All India level in 1997. 5 years down, then MCI recognized pediatric gastroenterology in 2002. 7 years down the line, MCI approved and notified in Gazette of India in 2009. There was long 12 years gap between the concept of DM in pediatric gastroenterology and actual practical application for the course. The first batch at IGPGI was started in 2011. So it was patience, perseverance, and effort. It is not easy to work in public sector, and it is not easy to get these things on a platter. Thereafter, the training programs, PDCC, we had 4 seats per year, open to pediatricians all over the country. And then we started DM 2 seats per year. And then you can see other institutions in the country took a lead. ILBS, Institute of Liver and Biliary Sciences, with Dr. Sareen as the head. And pediatric hepatology, 2 to 4 seats per year were created, and they started inducting people. Then thereafter in 2013, ILBS started 1 seat of DM in pediatric hepatology, not gastroenterology, but pediatric hepatology dedicated. And there, after that, PGI Chandigarh, DM pediatric gastroenterology, 2 seats, 1 sponsored, 1 open in 2015 per year. And now AIMS Rishikesh, they have started DM in pediatric gastroenterology 2 per year. Now regarding this, with the result we produced DM till 2019, till I was there at IGPGI. We produced 12 DM residents, PTCC, number of them, co-observers are coming from different parts of the country and also from outside the country. We had rotary postings for CMC Vellore, Osmania University, Trivandrum Medical College, dedicated to pediatric gastroenterology, they would get posted. And thereafter, you can see the number of people whom we trained as PDCC and as DM pediatric gastroenterology got spread all over the country, which is a very good contribution. And also there were some fellows from Apollo and Medanta Hospital and Gangaram who could actually take the position in different levels. My farewell in 2019, 3 months before my retirement at IGPGIMS, these are the people who had come for a deliberation for an academic feast, and which was attended by many of my students who were there. A new feather in South India. Pediatric gastroenterology unit in a public sector at SAT Hospital, Government Medical College, Trivandrum. A post of assistant professor in pediatric gastroenterology, February 2021, a recent development, supported by the Department of Pediatrics, Gastroenterology, Medical College Administration, and the government, of course. And with the result, dedicated patient services, increasing number of GI and liver, pancreas in children exclusively has been created. Endoscopic services and liver transplant also has begun. It's a big achievement for any place, for the people. It's not easy. It's a very difficult thing to get all these sanctions done at different levels, particularly in the public sector. So my hearty congratulations for the achievement, and I salute all of you having started a unit. That is how the milestone can be developed, and eventually you can have the Department of Pediatric Gastroenterology. You can start the DM course there. I will go to now cases. That is the crux of the day. I have one child who is 12 years of age, a girl child, and this child had fever of 10 months, and then pulmonary tuberculosis in grandmother 2 years ago. Weight was 39 kgs. Over a period of some almost 8 or 9 months, the child had a weight loss and anorexia. Was put on anti-tubercular therapy for 7 weeks. Ascites leading to respiratory difficulty was for 2 months. Bilateral pedal edema, which was spitting for 3 months. So all these manifestations, fever, followed by ascites, followed by respiratory difficulty, and also the bilateral pedal edema. Okay, on examination, weight after paracentesis very low, height also low, bilateral pitting pedal edema, and there was a lymphadenopathy. Right cervical, both axillary region, abdomen ascites present, LVP was done. No hepatosplenomegaly or mass was palpable after large volume paracentesis. Acetic fluid, large volume paracentesis, 7 liters of milky white fluid was drained out, which you can see here in the bag. And subsequently, the ascitic fluid showed low SAC. It was having lymphocytosis, triglycerides were huge, and no malignant cells or AB staining was negative. So this was labeled based on the color and the high triglycerides as cholecystitis. So clinical possibility, constitutional symptoms, 14-year girl, fever, anorexia, weight loss, generalized lymphadenopathy, and cholecystitis. It is nothing new for a gastroenterologist to diagnose cholecystitis. They see it in and out. But what is the important here? What is important here, the investigation showed Mantoux test positivity, ESR high, and liver function showing low protein, albumin also low, ionized calcium was low, and this child there was lymph node biopsy which was done, and that was showing the caseating granuloma in the biopsy. And this child, lymph node biopsy, cervical, multiple well-defined caseating granuloma, Z-Lancet stain positive, CT abdomen showing multiple large lymph nodes with central necrosis. And there were also hypodensities in the liver, necrotic lymph nodes in the mediastinum. So necrotic lymph nodes, all gastroenterologists are very significant and may be highly specific for tuberculosis. So this is disseminated tuberculosis with cholecystitis, and anti-tubercular therapy was given to the child. Medium, how do you treat? That is my point of attention for the gastroenterologist, cholecystitis. The important thing that we have to give medium chain triglycerides. It should be 85% of calories from the fat. Fat-soluble vitamins are important because we don't have the absorption capacity. Calcium supplementation has to be given. So that is how chyloscystitis has to be treated. And thereafter you can see it is antitubercular therapy plus nutrition therapy, which is very important in chyloscystitis. 8 months of therapy, weight gain from 33 kgs to 40 kgs, no ascites, no pedal edema, no fever, and protein albumin also improved in this child. So the message from this is milky white ascitic fluid should always be tested for triglycerides to confirm the diagnosis of chyloscystitis. Nutrition therapy with medium chain triglycerides is essential. Tuberculosis can present with chyloscystitis and optimal antitubercular therapy is curative. So this is the message from this particular case. This is nothing new for a gastroenterologist that they would not see chyloscystitis, but management of such patients, particularly it is not antitubercular therapy, but also the nutritional therapy that assumes importance. Now, you can see here another boy, 3-year boy, and progressive abdominal distension from 4 months of age. Now this child is 4 months of age. When he came to us was 3 years boy. No anasarca, no weight loss, anorexia, jaundice, bleeding, dyspnea or sinus. Nothing was significant excepting progressive abdominal distension in this child. Now you see here, ascitic tap was done elsewhere, which was showing reddish brown, 600 cells, all lymphocytes, no malignant cells. Smear for AFB was negative, as routine will do. Antitubercular therapy was given for 12 months. So that is how he was treated. So ATT was given and the ascitic fluid was showing lymphocytosis. You see, this is the picture of the child. It was when we looked at him and his hemorrhagic ascites, ascitic trap procedure aborted, but child was playful, not sick, even after the hemorrhagic ascites was actually, as a diagnostic tap it was done. Ascitic fluid showed bilirubin was normal, amylase has biliary peritonitis, triglycerides, creatinine, everything normal. So only we are not getting any information from the ascitic fluid, excepting we are excluding some of the problems. Now, this is the enigmatic ascites, starting at 3 months of age, going for 3 years, not responding to anything, not forthcoming. So with progressive abdominal distension, no systemic features, quite playful child. And usual cause of hemorrhagic ascites in any patient, if you see as a gastroenterologist, would be, is he having trauma, neoplasm, tuberculosis, pancreatitis, all these things would be thoughtful. But here we have a child who's at 3 months of age has started with ascites. Possibility, is it ascites or the pseudoascites? What it is. Now here we did CT abdomen. Large, non-enhancing, thin-walled, septated cyst measuring 30 centimeters by different 16 centimeters, extending from subhepatic portion region to the pelvis, pushing the bowel loops posteriorly. So there was no fluid seen here in the perihepatic or hepatorenal area. So intra-abdominal contents were pushed posteriorly, you can see here. And the cyst was extending into the scrotum. You can see here, all the changes are there, and no fluid in peripancreatic this space. So this is a cyst. Many years back, maybe 15 years back or 20 years back, an adult gastroenterologist from one of the hospitals in KM was in a meeting and asked me for a patient who was very young at 6 months of age, and they were finding ascites in the child. And the professor asked me, what could be the reason for this? We are not getting any clue. So I said, you do a CT and you'll find a cyst in the abdomen. So, clueless, fluid early onset is always a cyst in the abdomen. This particular case is inside the cyst. Long-standing history with no systemic involvement should raise the suspicion. Image will help in establishing the diagnosis. I think CT is the best image. I saw one child who had gone to Delhi, one of the premier hospitals, and this child later on to Lucknow, and the cyst completely missed there. And we did a CT, found a cyst and removed the cyst, and the child was perfect. Surgery is the only definitive therapy in these patients. Now, another interesting case. See, I'm not showing you something complex. These are all known to you, but I'm sensitizing you to the pediatric population where you may get this kind of patients. This is a case which is a foreign body. There's a child, 7-year girl with dysphagia, 7 days history. And this child came to me in the ward in HGPJ, Lucknow, and this was the year 1995, 96. Hypovolemic shock, 7 ERBC transfusions were given to this child. What we found, there was a history of triangular locket ingested by the child many days back. And this child landed with a massive hematemesis in the ward. Luckily, we had admitted the patient on the same day. Luckily, we were planning to do endoscopy on this child and try to actually retrieve, but we have not done. Before that, the patient bled massively in the ward. One of the DM residents, who was adult gastroenterologist, was working with me, and he was very intelligent. So what he did, when the volume was so low, he put pressure on one of the carotids with the finger, and the bleeding stopped. That is how this child could be salvaged. There was a hypovolemic shock, esophageal-carotid fistula was there, life-saving surgical extraction. I wheeled the patient into the OT at that time, re-explored after some time for carotid pseudoaneurysm, which is seen over here, and this patient survived. This was, although there was later Horner syndrome in this child, but this survived, and we published this case in Pediatric Surgery International then. And you can see how you can salvage the cases, that by presence of mind, by being very quick in things and the intelligence of the doctor. It is not always the book, it is not always the journal, but the skill, the intelligence, the wisdom, and the thought at that time which worked for to salvage this particular girl. Now another case, you see, emergency management. A child who has the case of Barchari syndrome confirmed after some time by us. EVL this endoscopy varicose ligation was done outside our hospital. 1 week later, this child came with upper GI bleed to our hospital. There was massive ascites, as you can see there. There's a coagulopathy occurring in the child. There is torrential bleed in our ward at that time. So this is the situation when this child came to us and he bled in our hospital, own hospital. Then what you see, it was Sunday noon. I was on call. I was called immediately to take a round. And in this, no BP, there was complete respiratory arrest for this child. I directed them, because I had learned from other cases in the previously that we cannot wait for blood transfusion like a drip. You pump blood directly with syringe. That is how we can actually salvage this child. LVP for ascites was simultaneously done. Plasma infusion was given. Stabilized because there was coagulopathy, upper GI endoscopy, post-GI ulcer, active bleeding, hemospray was actually given because it's a post-EVL bleeding from the esophagus, and we did very carefully lower and endoscopic sclerotherapy at that time for the varices over there, which was very, very minimal, which was done at that, but it was the hemospray and the resuscitation which actually solved it. You can see the team on Sunday, almost 10 doctors were involved because luckily Sunday and all the doctors were there for the round of the scheme and we could solve it. So wits, promptness, wits, teamwork are essential to solve such patients. Now another interesting, this was a child who came actually with apogea bleed. It was not a massive bleed, but he was bleeding. We thought that we'll go in and maybe he has got some duodenal ulcer or gastric ulcer or gastritis is there. But it was not very bleed. It never looked because there was no splenomegaly. There was no history of liver disease or EHPVO was not forthcoming. And I went with endoscopy to see for the lesion, and we could find a worm-like thing. This is the parasite, which we could see in the second part of the duodenum, and you can see here, he was sucking through this, and there was active bleeding from the duodenum at that time. And what I did, second part of the duodenum, there was active bleeding. We extracted this, the parasite, and we sent for microbiological evaluation and see what kind of parasite this is. And this child, thereafter, we put on antiparasitic treatment, and this was reported then by us by GI endoscopy. And this is Fasciolophysis baski, presenting an acute upper GI bleed in child, not actually described in the literature. And this is why the children of the villages, they go to the pond and they take water, and with that water there, the parasites go in and they harbor in the duodenum. So that is another interesting case that maybe that these lesions can be seen. These parasites may cause GI bleed, and it's only an exploration of endoscopy you can find them. I recollect another child that who had actually was 5 months of age, 5 or 6 months of age, but anemia, and we did upper GI endoscopy as a part of the workup, and we find there were hookworms in the duodenum. But the question was, why these hookworms in such a young child? He has not gone bare feet in the field. He has not walking. He's only lying down on the spine. But later on, we found that actually mother goes to the field. She keeps the child in the field, and the child will actually touch the soil with the feet while they are in the spine position, and the hookworm can go in. So these are some of the unusual cases. There is some disturbance actually. I think, Dr. Prasad, could you please ask mute? Please mute so we can have no disturbance. You know that extrahepatic portal venous obstruction is a common cause in northern India as a cause of portal hypertension in children. And we can have portal hypertensive colopathy, which we have documented number of cases. And hardly around 10 or 12% of them may bleed. And what we found is, but in this particular case, you can see here, there is one on colonoscopy. We found deep ulcer here in the colon. And you can see also the ulcer is over here. You can see the ulcer is over here. And in this patient, we did we do MRPV and MRC, or that tells about the vascular pattern in the children. So we were found that this EHPVO case was the patent inferior mesenteric vein, and also the superior mesenteric vein is patent. And what we did a shunt on this patient. Not responding to any kind of medical therapy, propranolol, this thing, reducing the pressures, not responding, treating as infection. Everything has been done, and thereafter we salvage this patient. How? And this is after the shunt surgery, when the pressures would decompress the system, the colon became like this. And this was later on follow-up, everything has become normal. So this is very interesting that whenever you have a Lovejoy bleed in a patient who has got portal hypertension, you may get this kind of ulcers, which are normally seen in portal hypertension. You'll see small ulcers or small bleeding area, but not just excavating. So we gave a name, apple bite colon, in a child, and published in Digestive and Liver Diseases 2020. Another thing, there was a case, was an unusual case of Lovejoy bleed, and bleeding, fresh bleeding per rectum, becoming anemic all the time, did colonoscopy, no lesion seen, no other clues, recurrent bleeding, repeat colonoscopy, nothing coming forward. So we were in a where from his bleeding, all other investigations done to find out the etiology. And on repeat colonoscopy, what we could observe, easy mucosal bleeding and fragility of the mucosa, what we call the friability in a way. And in this case was surprising, the INR platelet counts normal. But thereafter, as a part of curiosity, we tried to see if there's any hematological reason for this. And we sent this patient to Delhi for hematological workup. And what they did, they found that there's a platelet function disorder. So function of the platelet is causing the bleeding in this patient, and you just rub the mucosa, there's a friability, and that's how it was diagnosed as an unusual case of platelet function disorder. So far in my lifetime of 35 years, I have seen 2 cases of this kind who had platelet function disorder and causing bleeding per rectum. Now another case, very interesting, just focus on this case. 3-month-old child, constipation from 1 month of life, rectal suppositories to pass stools, passed meconium at birth, because we say meconium because of the fact that this is not Hirschsprung disease. Lethargy, poor cry, no social smile was observed. Child was lethargic, poor cry, no social smile was there. At 3 months of age, we expect social smile at 6 weeks of age. And here in 3-month-old girl, no birth asphyxia, sluggish deep tendon reflexes, macroglossia we can see here, and excessive hair on the forehead. These are some of the features which are seen in children with hypothyroidism. So possibility of hypothyroidism was there, and TSH was very high. You see, normally we take up to maybe 10, and the ranges, lab ranges vary. So it is 75, very, very high TSH is there, and T3 is undetectable. Now, on examination, that is why we say always, don't just write prescription while you are sitting on the chair and table. You should always examine the child. We incidentally detected massive hepatomegaly around 6.5 centimeter firm, bosselated. Features of cardiac failure were there. So anemia, congestive heart failure, this hepatomegaly, constipation, hypothyroidism. These are the problems. Multiple lesions in both lobes of liver you can see here, which are shown in the arrow, with early enhancement in arterial phase and persistence of enhancement in delayed venous phase. And the diagnosis for this patient was that there is infantile hemangioendothelium. This is the characteristic, these are the characteristic features of any baby with anemia, congestive heart failure, and hepatomegaly. And now then, how will you build the story? This tumor is known to secrete some deiodinase that inhibits T3 and T4. So it becomes consumptive hypothyroidism. So what was happening in this child? The tumor was secreting this inhibitory mediator that was causing hypothyroidism. Hypothyroidism indirectly was causing the constipation. Now what happened? Very interesting. How will you manage this patient? That is interesting. And here what we see, we have two aspects. We have to resolve constipation. We have to resolve the tumor problem. So for the tumor, we give no response to steroid. Normally in hematologic endothelioma, who are not very sick, you can give steroids, and you can, if they don't respond to steroids, then alpha interferon can be given. And that was given, but there was no response at 3 months. Then we switched on to another therapy which is supposed to work, which might work, propranolol. Propranolol 2 milligram per kg body weight was given, and the tumor started regressing. As the tumor started regressing, along with that, we had given the thyroxine, and we had to procure T3 also. There's a deficiency of T3. And T3 had to be procured from outside the country, and the supplement which was arranged and supplement was given. So constipation resolved daily. Tumor regression simultaneously took place with the therapy of propranolol. Improvement in growth and milestones. Requirement of T4 and T3 as the tumor improved, this also the requirement fell down. Ultrasound after some time showed no space occupying lesions, that is at 15 months of age. You can see here before propranolol, the tumor in the liver, hemangioendothelioma, and after propranolol, how the liver looks like, normal. So that is a story about this child. So here we can see very intriguing that constipation, consequence of hypothyroidism as a consequence of liver tumor. Therefore, you have to treat tumor as well as the hypothyroidism, and then the things will get resolved. Another child, this is very, I think a lot of gastroenterologists must be seeing, and pediatricians are fed up. I am also fed up to see this kind of cases now and then in the hospital. 13 years old boy, Kuldeepak is called in Hindi. Why that Chirag? That means the child is very, very precious and the one who is being pampered by everybody. Recurrent abdominal pain for 2 years, periumbilical, insidious onset, slow rise, mild in severity, short lasting 20-30 minutes before going to school. No nocturnal symptoms. So pointing the site of the pain with one finger, this is very important. No constipation, vomiting, constitutional symptoms, fever, anorexia. So there is a periumbilical abdominal pain which is recurrent, and severity is mild and the short lasting. Then growth, normal. Height, weight, absolutely normal for age. Blood pressure normal. Abdomen, nothing really forthcoming. Apparently alarmed parents. History of irritable bowel syndrome in mother. So mothers, in such cases, we have a difficulty. So parents are very apprehensive because they are fed up with the quality of life which the child has. The pain is real, but then they have this problem. Now you will look at the family history. This child lives in a family, joint family with paternal grandparents, and mother is a nurse who was IBS. Father is an engineer, only male child in the family. And here you can see 3 sisters are there and only child, index case. Now, doctor shopping. Generally, you know, I also know that they go for shopping from one doctor to another in search of something which will make them magical cure. 6 doctors in 12 months, multiple blood urine tests, everything done. Empirical ATT also given, which is a problem in this country. Mesenteric lymph nodes were seen, which is normal in children, depending upon the size. CT abdomen twice done, nothing. Appendicectomy also done. And UGI endoscopy normal, colonoscopy normal. Mother has similar workup done for IBS, has contacts with various doctors because she's a nurse. So a complicated problem. How do we resolve it now? See, always look at, in these cases, you should always look at stressors. It is not only pertinent to this patient, other cases also who have recurrent abdominal pain and nothing, no alarm symptoms are there, alarm manifestation. Only male child in the family is one. High academic expectations, we want achievers. Change of school, new environment, misses old friends because of the school change. Abuse of school teachers, if they abuse them and they get these stressors. Family history of IBS, mother here. Mother pushes work up too far. Grandparents push mother too far, demanding answers as she's a nurse and this is the only child in the family. And then here you can see mother was reluctant to accept the diagnosis of functional abdominal pain, also pressurized by the in-laws for getting a solution as she is in the medical profession. Father, mature in understanding, accepts the diagnosis, convinces the grandparents because he is the son. The Bahu cannot. Daughter-in-law becomes difficult. Changes back to old school, no academic pressures, limits family expectation. So he was actually changed from one school to another school that was a stressor for him. And follow-up, child was asymptomatic, no pain, abdomen, school performance restored, second rank in annual examination, mother and grandparents convinced. So this is the story of recurrent functional abdominal pain, where counseling is very important from the doctor's point of view. They come with bundles of investigations, bundle of tests, and they search a magical cure for that. That has to be explained to them. So another aspect, I hope I am on time. I'll just see. Oh yes, this is fine.
Go ahead. I think it's very interesting. I think you can go ahead.
Okay, cirrhosis in young children. See, I gave a talk in PGI Chandigarh some years back, and they had asked me to present how the children's liver disease is different from the adults. Secondly, Dr. Dilavri was chairing the session, and he also wanted answers on the acute liver failure in children. How is it different? Adults, with all the apology they feel, their area is difficult. But I feel pediatric area is much more difficult. Whether it is IBD, it is our liver diseases, they are much more difficult. Much more difficult to treat also, much more difficult having a course and investigations to be done in them. Now here, I have put in a chronological way. See, at birth, we may have liver disease because of what's called a neonatal hemochromatosis. The concept these days is cirrhosis of liver develops in a child in utero in this condition of what's called neonatal hemochromatosis. They were present at day 5 with coagulopathy, with acute liver failure. And if they survive because of one or the other reason, they may develop cirrhosis of liver. So another area which you all know, biliary atresia, one of the very fast cirrhosis, unless it is treated and surgery is done within first 8 weeks. Neonatal cortical cyst. See, it's not a cortical cyst of older child or adult. Children have a liver problem. It reacts very quickly to the insults. If you have obstruction of the biliary system as a result of cortical cyst, although it is uncommon in the infantile age group, 5% of all the cholestasis, but it can result in a severe secondary biliary cirrhosis, which is unsolvable at 5 or 6 months of age if we miss it. That's why nowadays all people in obstetrics, they do a routine ultrasound to rule out such congenital anomalies. And there are children who come at birth. After birth, they come to you, sir, there's a cortical cyst, a suspicion has been raised, so could you have a look? So cortical cyst becomes another important thing. Then we have metabolic disorders like galactosemia, tyrosinemia, bile acid synthesis defects, progressive familial intrahepatic cholestasis. Now the term has been changed. They are called transport defects of the biliary system. So difficulty, further if we see, then we have mitochondrial cytopathy is one of the fatty acid oxidation defects, respiratory chain defects, other metabolic diseases. Now, these conditions are not one investigation you get the diagnosis. You have to use biochemical, you have to use what's called the genetic testing, you have to use other metabolic testing in these children. It is not easy. They may look alike, but you have to investigate, you have to find out. It is not developed. All the tests are not developed everywhere in this country. It is a huge expenses are also there. So, but many of them are treatable disorders which you can really do well after you're doing a specific treatment. Now you see here. Now you must be knowing there are autoimmune, Wilson, hepatitis B, hepatitis C. You are well versed with these conditions. I need not to dilate upon them. So I am focusing on this area which can also present in the adulthood. There are a lot of transportal defects now, PFIC type 3, which can present in adults. I was reading about citrulline deficiency. It can present also in adults. So Wilson disease can also present in adults. So there may be adult onset liver disease which can take place. So the roots are in the pediatric age group. I will just show a simple case at 16 days, how difficult it is. A boy, greasy stool from that means greasy means we as gastroenterologists know is fat in the stool. Now fat we know it can come from pancreatic insufficiency there. There may be maldigestion, malabsorption, there may be a liver problem. So all these things, 3 organs can give rise to fat in the stool. Accommodating nodules in this child, 7 days, coagulopathy. Jaundice with high colored urine. Again, it points to the liver problem. Pigmented stool. Why we say pigmented? Because we have to always distinguish between biliary atresia at this age and the non-biliary atresia patients. So here is the index case. With malabsorption or we can say fatty stool, coagulopathy, jaundice with high colored stool, and examination, ecmotic spots, icterus, abdomen, liver 3 centimeters, but soft. Now here, eldership, his family history is important. Family history is 7 years, child, eldership, sibling, neonatal cholestasis that child had, resolved at 4 months of age, no pruritus. Pruritus, why we say there are certain conditions like PFIC, where you may have pruritus, alpha-1 antitrypsin pruritus, sclerosing colitis pruritus. But in this case, there was no pruritus. Steatoria from 11 months of age in that child who died 7 years. Ecmotic, night blindness, fractures after trivial trauma. This was the story in another SIP in this child. Now, child has been brought very quickly because they are scared that this child may also develop similar kind of problem. This child has bilirubin 15.9, conjugated variety, AST/ALT very high, albumin a little bit low, gamma GT may be normal, we can say. INR is also after vitamin K. It is from 13 INR. You can see the scale of like picture. And 1.2 after correction with vitamin K. So it's a correctable coagulopathy. Now, here we have low gamma GT neonatal cholestasis, no pruritus. But in the why I say no pruritus, because not applicable here in the child. He is 16 days old child. He will not express that I have itching on the body. It is only after 4 months, 5 months you can appreciate itching in any child. There may be irritability because of pruritus that we cannot understand. Steatoria, fat soluble vitamin deficiency, affected sibling here. And sweat chloride is the part of cystic fibrosis. Somebody has done, I would not consider very well, which is normal. Stool fat very high. And now here we think of, by always in every child, we should do in these kind of situations bile acid level in the blood. And they are available now in India. And normally is more than 3.2 to 10. It was low, 0.3. So what does it mean? It means this child has bile acid synthetic defect. And there are various varieties. One of them is this, is a common one. And what we do, proven by mutation study and diet supplementation, ursodeoxycholic acid was tried in this child. It doesn't help really, and cholic acid is the treatment. And cholic acid, unfortunately, was not available at the stage in India. And the cholic acid now, I think Amazon sells cholic acid. So we have to see, many of the people from Chennai have told me that is available on Amazon site. So this was a fatty acid oxygen defect, and we know bile acids can differentiate. PFIC and this bile acid defect can just overlap in medical, in presentation, but it's the bile acids level that can differentiate the two, really low here. And cholic acid is curative for bile acid synthesis defect. This case prompted me to write a review for an international journal, current view on bile acid synthesis defects, although I am not an authority. It is mostly done by Cincinnati, Ohio. These have been described by them, and the series is from them, and it was well accepted because it was very practical how to approach the case of bile acid synthesis defect in literature. This shape. This child at 3 years, shape, 4 years, the same child, how the shapes are changing. That's why we say children are different from adults, because they are always in a dynamic phase of growth. They change. And you see transient neonatal cholestasis. They are chubby cheeks. Normally chubby cheeks, everybody knows, is glycogen storage disorder. But we should always keep in mind that this can be another condition. Chubby cheeks, but over the period of time, they waned with time. So here you don't find chubby cheeks in the third diagram. Transient neonatal cholestasis, liver biopsy, cirrhosis with steatosis, encephalopathy at 1 year after fruit juices. Something happening with the fruit juices. So diet becomes very important in children, the dietary history. Carbohydrate aversion, protein craving. They crave for proteins more. Ship death with liver failure at 4 years. Important family history. Now in this child died of liver failure at 4 years. Same child. And what was the reason for that? The diagnosis is strain deficiency, citrullinemia. And there are various varieties of type 2 generally, which is diagnosed by plasma tandem mass spectroscopy by genetic evaluation. But the cure, if you diagnose this child properly, the cure is by liver transplantation. They require liver transplantation. They can be treated very well. And the difference, they look like what is called uracycle defect. But the difference is, there are subtle differences between the two conditions. So, biochemistry, tandem mass spectroscopy, mutation analysis will give you a diagnosis. So, in a differential diagnosis of chubby cheeks, family history death, think of citrulline deficiency as one of the causes. In wealth, see how we have India in pediatric gastroenterology contributed. It is not that Indians are inferior. Indians can do wonders. If they have good labs, they have good opportunities, they are great. And this is one of the papers we published in Journal of Hepatology, which is not easy. It's a very high impact factor. Safety, complications, outcome of large volume parasitosis with or without albumin therapy in children with
Sir, you got
Your is muted, Doctor. Your phone is your mic is muted. Okay.
Now you can see, you can hear me.
Yeah. Yes.
Please tell me. It automatically happens. I don't know why. So safety, complications, outcome, large volume. In world literature, I wrote a review once in very early in 2001 year. I wrote a review for how to ascites because of liver disease in children. I could not get a reference whereby we could see how much to drain, what volume, when should we drain, nothing was known. Therefore, this prompted me, that paper prompted me to look at this condition. And how we did it with my DM colleagues. So we did also looked at plasma renin activity, the post-parasympathetic circulatory dysfunction. I will not go into the detail, but I will show you the results. See, severe ascites, so we could tell the world that how you should drain, how much you should drain, what are the problems, like what we have adults, we know how much of fluid has to be drained. Large volume paracentesis is required in children, mostly in the developing countries, because we have many other conditions we can give this kind of a problem. Single time large volume paracentesis as base, day 6 assessment. So what we found, those cases where albumin was not infused, 40% without albumin infusion, asymptomatic hyponatremia. None if albumin was infused. Post-paracentesis circulatory dysfunction on day 6, 67% without albumin infusion, and 12% with albumin infusion, very less, very significant. And this, because of this post-paracentesis circulatory dysfunction, their outcome at 3 months follow-up, recurrence more, mortality more, hospital readmission more. So how to go about it? If we best strategy for draining, doing LVP in severe ascites in children, under albumin infusion is the best. And we can give 1 gram per kg of body weight. And overall restriction of acidic fluid extraction should be less than 200 ml per kg body weight. So that is a guide that preferably do under albumin cover. And this is the volume to be drained. But we have poor country, there are a lot of poor patients, they cannot afford albumin, is expensive and cannot afford. And in those we have shown in a limited resource setting of non-availability of albumin, restrict paracentesis flow rate in albumin non-infused less than 680 ml per hour. So keep it low, and this may help the patients to avoid post-paracentesis circulatory dysfunction and also the hyponatremia. So this is the message from this particular study which we have done in India. Now, second aspect, see, there is incomplete things. If we just discuss cases for gastroenterology forum, to my mind is very, very, it's incomplete. We must have some research taste. Doctor, we have our beloved doctor there, Narendra has a lot of research. So this is, I have worked a lot on the extrahepatic portal venous obstruction. And a lot of papers I have published, more than maybe now 28 publications. Most of them are international journals. And it's a common problem in the North India. But here also in Bangalore, I have been seeing cases of EHPVO. I have tackled them very well. And here you can see this is the march, how research started and how it is going on extrahepatic portal venous obstruction. This will interest the surgeons also, and also the gastroenterologists. Now here, number of things. We go for EST, EVL, do this thing, do that, but ideally what happens? We show poor quality of life because of massive spleen. They have anemia. They look very dull. I have proved these things. Ideal minimal hepatic encephalopathy were published in Journal of Hepatology, 2 papers on this. And they develop growth failure. After 16, 17 years of age, if you find the child has not been actually treated properly, may have growth failure. They stay short. This is a huge concern for the generation of now. Issues of large spleen, they look very dull, protuberant abdomen. There may be portal hypertension enteropathy. There is malabsorption. There may be portal cavernoma, cholangiopathy. This is a concern now. To me, is this cholangiopathy, what we call biliary cholangiopathy, in these patients of extrahepatic portal venous obstruction. In this endeavor, now we did one study, which I will not go into detail, biliary structural changes, biliary vascular changes, what happens. We used methods which are endoscopic ERCP in older children more than 10 years, magnetic resonance cholangiography, MRC, MRPV, photovenography, endoscopic ultrasound. These are the equipment, these are the methods used in these children. It was a robust study. There is no pediatric or adult prospective study where combination of the above techniques, all the four, have been used for evaluation of portal biliopathy in non-cirrhotic patients. I think even in cirrhotic, because they don't give time for these kind of studies, so it has been done. And what we found, now I will show you the results of these patients. So these are the results. Some of the, I don't want to go into the detail of these results. And you can see some of the biliary changes on MRC in this patient. These children, you see here, short CBD, right? And right hepatic duct stricture is also there. Right hepatic duct stricture. There is structure in these asymptomatic portal, this EHPO cases, long CBD structures in children because of EHPO. Again, cholangiopathy, you can see the biliary changes in the MRC in these patients, wavy changes you can see, and you can see the smooth indentations over here, the biliary tract. You can see the angulations which are taking place in these patients. But majority of our patients were asymptomatic, yet they had these changes on MRC or MRPV. This is endosonography which was done in 72 children prospectively. You can see here the perforators, intracolloidal varices on endosonography. You can see the CVD calclysine on intramural gallbladder collaterals also seen in these children. So what we see is the changes are profound in EHPO cases. Now what is the connotation of this? We have seen that if they have SMV blocks, superior mesenteric, besides the portal vein block, they have associated superior mesenteric blocks, they get all the problems in this tract, because this anatomy is such that the SMV block produces the biliary changes which are huge. So therefore, the summary of results, 92% of portal vein block have this what is called cholangiopathy. 85% of them are asymptomatic. They are silent. They are doing very well. You have done banding. You have done EST. They are asymptomatic. No problems as far as biliopathy. But on search, you will find. Age at study and duration of these. As you increase the age of these children, you find more and more symptomatic, more and more changes are taking place. That is the length of the portal hypertension. Normally what we see, we look at LFTs, alkaline phosphatase elevated or gamma GT elevated. Pitch is one of the markers of biliary obstruction. No biochemical changes in asymptomatic cholangiopathy. We did not find any change in alkaline phosphatase or gamma GT. That means they cannot, these two parameters cannot pick up the obstruction or cholangiopathy in such kind of patient. Overall, 60%, 63%, 2/3 of asymptomatic cholangiopathy had grade 3 MRC. There very good changes were there, cholangiopathy. And 64%, 2/3 of asymptomatic PCC had SMV block. So SMV block significantly associated with cholangiopathy, SMV block significantly associated with US changes. Once you have SMV block, it's very difficult to take up them also for the surgery at times. And they have a bad biliary system, which cannot be managed by the shunts. So this was the message was that we should conclusion first and the largest pediatric study on cholangiopathy in children, prospective and comprehensive evaluation, using MRC, MRPV and US routine evaluation of PCC. So we are not recommending after this study, we should do, so I have been doing here in Bangalore now, we should try to, before we subject them to surgery, shunt surgery, we should do, one is the Doppler ultrasound, but along with that we should do MRC, MRPV. So that tells us clearly whether there is cholangiopathy, where the ductal system is obliterated, there is patency of the. Recently, we had one child where Doppler had shown everything good excepting portal vein block. When I prepared for surgery, because he had hypersupplement, he had large gastric varices, and he has poor quality of life, short stature, and he was around 13 years of age. So when I did a part of this MRC, MRPV, we could not locate the actual splenic portal vein was totally blocked. There was a complete block of that, and with the result, now you have to do shunt. So how will you do shunt? So he was subjected to splenectomy devascularization because of the huge spleen, plus a make shunt because there is a huge collateral, and that was being shunted with the left renal vein. So make shunt arrangement was done in this case. So this is last slide. Neonatal cholestasis is my actually dear subject. I have been working this for a long time. And recently what I have done in a prospective study, people have developed a stool card for identification of early biliary atresia. But what I did, I went a step ahead and identified that how will a mother identify that her liver of the baby is on fire? The fire will not, stool color distinguishes biliary atresia versus non-biliary atresia most of the times. But it is the urine color which becomes important. Taiwan color, you must have heard Taiwan model of biliary atresia. But here we have recently in 2020, you can see this is urine. If you stay in the diapers, a pregnant woman is given and educated. Once the baby is born, you find that there is pigmented, this is staining of the diapers with this kind of urine. Suspect liver disease. Then is the question, what kind of liver disease it is? And also we have developed a stool color, which is pale. This is for biliary atresia. This is called the pigmented stool. These are the models. And I took the help of Dr. Mai Wei Cheng, who has developed the Taiwan stool card. She helped me in giving me the card, which was used for comparison in the research work. So this is the card. I think Kerala is one of the advanced states of this country, which we are proud of. And probably in the health system, they can actually, Tamil Nadu is trying to integrate this card into their immunization schedule and give it to the mother so that they can identify. Here the problem is the doctors don't identify. They just leave them and they become very bad. Survival becomes difficult for these cases. So therefore Kerala health system can actually try to inculcate or incorporate this card into their system. So with these words and this my special thanks and appreciation to Trivandrum Gut Club, and I must thank all of you for giving me this opportunity to share some of the problems. I didn't want to show conventional things to a gastroenterologist, which I would show to a pediatrician. So I took a different lead today. I wanted to show something different. You know varicose bleed, you know what is liver disease, what is cirrhosis, what is Wilson. This is all you know. And I want to take a lead and take you down where you may help the pediatric community for this healthcare. Thank you very much. Thank you.
Dr. Yacha, we thoroughly enjoyed your presentation. And I think there are many of these things I was hearing for the first time, the facial biscuit, the Munchausen's, apple bite colon, platelet recitrin deficiency. And I think I never thought that it's so much interesting was the pediatric gastroenterology is such exciting subject. Thanks a lot. And I think I would like to have some response. We have got our senior pediatric gastroenterologist, Dr. Jairam Das. Dr. Jairam Das, would you like to give any comments or suggestions?
Narendranath, it is still not too late to change to pediatric gastroenterology. You are welcome. You're welcome. Dr. Yacha, I can address you as Dr. Yacha. I'll gently introduce myself. I was Saroj Mehta's first DM student. Santosh and Saroj Mehta's student. Namaste ji. SR Naik is my teacher, colleague, senior colleague. Jang Bahadur Delawari. These are all the people who are. I was in PGI 78, 79. I belong to Trivandrum SAT Medical College. But when I came back, the government said, look, we are not ready to start pediatric gastroenterology. And then I was in Oman, I was in Muscat for 27 years. In a way, we are both equally young. So you are my contemporary in India. I was outside India. I came back in 2006 and joined KIMS. I worked in KIMS after that. It was a fantastic presentation. Even though we have not met, I knew that about the tremendous amount of work that you were doing, and it was an outstanding presentation in the limited time that you were given. So it is really nice.
I salute you. I salute you.
Okay, I think there is a question from the, there is one, Dr. Shrija Sugunan is asking, if you are taking 200 ml per kilogram, over what time should it be taken out? Any comments, Dr. Yansha? Yeah.
Hey, you can, whenever the patient has symptoms, there's a severe ascites, the respiratory embarrassment is there, and distension is huge, child is uncomfortable, you may actually do large volume paracentesis. Nowadays, we always do diagnostic followed by the large volume paracentesis. So that is the way. You can do anytime, but you have to see that you don't have any other problem associated.
How many hours? That's what the question is.
Our till the time, it is actually 200 ml. Suppose we have a child who is 20 kilograms weight. 20 into 200 will be 2,000 liters. It will be volume based actually time. So around 2,000 ml I will drain and I will stop. But it should be a slow draining. It should not be fast draining. That's important. That's the key in this.
Any other comments? Dr. Prashant, would you like to say anything? Dr. Prashant?
No, sir, it was really a brilliant lecture by HS sir, showcasing the huge volume of work that he has done over 30 years or so. I think there are not many questions in the chat box.
Dr. Gupta is raising hand.
Sir.
Dr. Gupta from Jaipur.
You're welcome, Doctor.
Just a comment. It's a wonderful talk by our respected Yacha sir. He has been always wonderful. He's a great speaker, and his experience is so much that we always learn many things from his talks. And today also we have learned a lot, especially about this large volume paracentesis. We usually at a common pediatrician always worry about the volume of the ascitic fluid taken. We usually limit us up to 50 ml per kg. But as he has told that we can easily remove more than 100 ml per kg, even up to 200 ml per kg. So that at a single time, we can get rid of the ascites, and it should be done under albumin cover.
Yes.
And second thing that he has told that EHPVO, it's a big sir. We are having so many cases of EHPVO. So can you enlighten us with at what time should we go for the shunt surgery? That is the big issue. Actually, surgeons want to avoid the shunt. So we have to tell them that this is the time that you should go for shunt surgery.
So first of all, my dear friend Gupta, I'm very grateful to you. It's always a pleasure to see you and listen to your comments. And regarding this EHPVO, you see, I had many debates with the surgeons and on very big forums with adults, with surgeons which are pediatric also. I feel that there's an indication for shunt surgery. Number one, first of all, choose the surgeon who knows shunt surgery. Don't send to everybody, Tom, Dick and Harry, who doesn't know. I will not send it to that surgeon. Then I am doing a disservice to the child. So shunt, they should be experienced in doing a shunt. I would Say gastrosurgeon is the best person provided he has experience in the shunt surgery. That is first thing which you should do. Second indication would be if you find that these gastric varices are large, huge. They are F3, or there's actually classification F2 to F3. They're likely to bleed less, but when they bleed very badly. And why should a patient who has not cirrhosis, who is EHP or benign disease, a long-term life, why not to do shunt surgery in them? Second thing, hypersplenism. You can't, we have done a study where we have shown we can't tackle hypersplenism if the platelet count is less than 50,000. If the TLC is less than something like 1.5, if the spleen is very large, more than say 6 centimeters, then our propranolol also does not work. But those who have, there we have done in the intrahepatic portal hypertension cirrhosis, when we gave propranolol, we could do the liver biopsy percutaneous in them. We could reduce, we could improve the platelet count. So second is hypersplenism. Number 3, large spleen, that is the quality of life is bad for the child. Short stature, do it pre-pubertal. Don't do after that, there's no point in doing this shunt surgery on this patient. So we should choose on this basis that these are the indications. I would like to go for all patients for shunt surgery, if the surgeon is very good. And I would not wait for a long time. I'll not keep on dragging EST, EVL, propranolol, this thing, that thing. No. Go for shunt if our surgeon is very good. Post shunt, give them aspirin. Very important, for a period of 2 years you should give them, because these are sclerotic veins and they may re-thrombo. That is why they have got shunt blocks. So therefore, that precaution you have to take. So if the bleed is not controlled, which is very unusual these days because of the good endoscopic services, and therapeutics is very good. So I would go for the shunts in these patients.
Thank you, sir. We all
One more question, sir.
Yeah,
What is the minimum age for shunt surgery, sir? Because many surgeons, they avoid...
Oh, yes, your questions are very relevant questions. I tell you that better is to delay the shunt surgery beyond 5 years. Don't do it before 5 years. Because their vein size is small and your surgeon may not have expertise unless you're a vascular surgeon. We are not in a hurry to go for the shunt surgery at 4 years or 3 years. What is the hurry? There's no hurry. Therefore, do it by your time. Go by 5 years, 6 years, 7 years. That is the best. But do it before 10 years. That is the time.
Okay, there is one more. Is symptomatic portal biliopathy an indication for shunt surgery?
This is very interesting. There's a huge debate in the world. Can it reverse or it cannot reverse? But I think there's a difference of opinion. Some of the studies have shown that it reverses. Some of the studies have shown it does not reverse. Some of the studies are showing plus minus results.
Okay.
I think before you have, it is symptomatic, sir? Symptomatic, he's asking?
Yeah, I think just...
No, sir.
Asymptomatic, sir. Asymptomatic.
Asymptomatic.
Asymptomatic, yes, you must do. You must do, as I said, the indications are there. Biliopathy, asymptomatic will not manifest to you. They will have no symptom. But you do, if you are contemplating a shunt, do MRC, MRPV or MRC and see if they have biliopathy. All the more a reason that you should go for the shunt surgery.
So
Don't wait for symptoms to develop. They have no option. I know patients where we don't have any option after symptoms have developed to get shunt surgery and reverse it. Surgeons will not operate on biliopathy directly on the biliary tract. They hesitate.
So thank you, sir. I think I will request.
Can I ask one question, sir?
Yeah, go ahead.
Can I ask one question? And Dr. Thomas Status. I wanted one or two clarifications. What is the mechanism of chylous ascites? Is it anything to do with the thoracic duct? That is number one. And the platelet abnormality, you had 2 cases. Is it Glanzmann's disease? And the third one is how does propranolol work in the liver tumor?
Tumor, yeah.
Those 3.
We don't
Yeah,
know.
those three
The first question you asked about the what was the first question?
Kailas ascites mechanism.
That is lymphatic congestion. It is not thoracic duct injury as such. That we generally know that there is a trauma and there is a thoracic duct injury and therefore Kailas ascites. In this particular case, it was tuberculosis. So the lymphatic blocks will take place and produce Kailas ascites. What was the second question?
Glanzmann's disease, your platelet abnormality, you had two cases. Was it
I
Glanzmann's
sent
disease?
one child to the Indian Institute of Medical Science and Hematology, and they diagnosed platelet dysfunction. I don't know further beyond that. What is the
They are Glanzmann's only.
Maybe that is the thing. No,
Okay. And propranolol in liver tumor.
we don't know the exact mechanism. Propranolol reduce. We know propranolol reduce splenic pressure is a reduction in this, but exact mechanism how propranolol reduces the hemangioendothelium is not really clear.
Thank you, sir.
Okay, Dr. Harish Karim, I think we all had our hearts content and we are all satisfied. We are more than 100 participants. Dr. Harish, can you have the final word?
Talk for messages pouring stating and no one wanted to, and we really enjoyed. Thank you very much, sir, for that. And our appreciations and from all of us from Trivandrum, and also thanking you once again for accepting the invitation and presenting such a lively talk, and learned a lot, sir, from you. And also I would like to thank the moderators for the session, Narendra sir and Dr. Prashant, and also the sponsors of today's meeting, Sun Pharma. So once again, good night, and thank you all for attending. Thank you all the delegates and members for attending and sharing your experience. Thank you, sir.
Thank you, Dr. Karim. Thank you very much. So nice of you. Thank you, Gut Club Trivandrum.
Good.
Thank you very much.
Sir.
Okay.